So respected chairperson and by my colleagues and ladies and gentlemen. Nasik is very famous in India. Even from the childhood, we know that Nasik is there, and something is there in Nasik because every part of the India people know that Nasik. It was a lot of inquisitiveness for me also, because this was my maiden visit, and I enjoyed the beauty and the scenic beauty of the hills and hills and covered with clouds and sometimes rain itself. So that ameliorated the some pain or some discomfort of the NH conditions close to the Mumbai. Actually, this topic was not to be given by me. It was supposed to be given by Professor Tofan Kantitolai. He has done a commendable job. All his slides, whatever he has done everything. But his flight got cancelled. He called me at 10 p.m. Dr. Jena, can you take up this case? I said, okay, bhej dijiye. So he sent me at 11 p.m. I just checked it. He has done a commendable job. When I saw the way he has prepared the slide, I got an inquisitiveness to learn from you by discussing with you. So there is no ending to learn. I decided let's go ahead with the approach to the child with anemia. If we look at define the anemia in children, anemia may be defined as a reduction in the red blood cells mass or blood hemoglobin, a concentration. That is the general definitions of the anemia is concerned. And more precisely, anemia in children is defined when the hematocrit or hemoglobin is at or below the 2.5 percentile of the age and sex based on normative data from healthy individuals. If you take the healthy individuals of 100 or thousands, if it's at or below say 2.5 percentile of the normal individuals of the hemoglobin and hematocrit, then the patient is having the anemia. No need to remember on these clumsy things, we'll skip because this is another WHO definition of anemia, which is very simple and pragmatic and clinicians can remember very easily. If it is less than, WHO defines, if it is less than 5 years age, hemoglobin less than 11, we would call it as anemia. Similarly, 5 to 11, it will be 11.5. So 12 to 14, it is 12. If it is a young girl without pregnancy, more than 15, we call it as 12. If it is less than 12, we call it anemia. If it's a boy more than 50, we call it as the 13 is the normal limit. If it's less than 13, that we call it anemia. That's the simplest way of the WHO classification of anemia, which most of the pediatricians or the clinicians will be very easy to remember. Again, the same WHO has categorized the gradations of anemia: mild, moderate, and severe. And no need to remember every point of the decimal. In general, if it's less than 7 gram %, we call it as severe anemia, both for pediatric and adult patient also. If something between 7 to 10, we call it as moderate. If it's 10 to below normal, we call it as mild. That's the simplest way of classifying the grade of the anemia. So people look at the physiology of hemoglobin level in infancy. At birth, hemoglobin is very high, say more than 14 gram %, 90% is of the fetal hemoglobin, around to say 14 gram % or more than that. It gradually falls and falls at about 9 weeks or at the end of the 2 months. It attains the nadir of say 12 gram, then it is gradually raises and maintains around 12 gram %. That's the normal trajectory of hemoglobin after the birth. And if you look at the causes of anemia in pediatric age group, can be broadly classified into impaired red cell production, increased red cell destruction, and blood loss. Impaired red cell production can be red cell aplasia. We call it includes red cell aplasia includes say parvo B19 infection, so diamond blackfan anemia, the transient erythroblastopenia, Fanconi anemia, aplastic anemia, and subleukemia also. So, there can be ineffective erythropoiesis also, which could be due to iron deficiency, folic deficiency, and chronic inflammatory disease, and so on. So these are the two main subcategories of impaired red cell production. Means the bone marrow or the stem cell or the erythroid cells are not sufficient enough to produce the red cells or hemoglobin. The second category is that if there is an increased red cell destruction, it could be due to either red cell membrane disorders, we call it as hereditary spherocytosis or elliptocytosis. It could be due to red cell enzyme disorders. It could be due to G6PD deficiency or pyruvate kinase deficiency, or hemoglobinopathies, which thalassemia, sickle cell, hemoglobin E or various combination, or it could be due to immune-mediated destruction of hemolytic anemia, which could be due to hemolytic diseases of the newborn, which is peculiar in the infancy, and then it could be due to autoimmune hemolytic anemia. So these are the subfractions of increased red cell destruction. So blood loss could be, there could be third category, increased blood loss, which could be due to fetal-maternal bleeding or chronic GI blood loss or inherited bleeding disorders. So in this way, the causes of anemia can be divided into impaired red cell production, increased red cell destruction, otherwise called hemolysis, or blood loss. Accordingly, we have to approach the clinical features, the laboratory parameters has to be integrated to categorize to which category the patient belongs. Accordingly, you have to search for the etiology by going over history, clinical examination, and specific investigation depending on your clinical finding. So if you look at the intrinsic red cell blood defects or causes of hemolytic anemia in children, as I have already told, there can be increasing the red cell blood cell defects, which could be due to hemoglobinopathy, which is the most important one, which is called either sickle cell, thalassemia, E disease, or various combination. I have already enumerated. There could be membrane defect, there could be enzyme deficiency, I have already told. If there is a extending hemolytic process includes autoimmune hemolytic anemia, which could be warm reactive or cold agglutinin or paroxysmal cold hemoglobinuria. There can be hypersplenism, there can be systemic diseases which know infections, liver diseases or renal diseases, drugs and toxins. There could be microangiopathy and so many varieties. There can be mechanical damage by the artificial valve, Wilson's disease, or combined mechanism of both intrinsic and extrinsic causes. So hemolytic anemia in children can be again subclassified into intrinsic or extrinsic, and depending on the criteria also, there are various diseases also. So let's now to see how to approach the child with the anemia. If a child presents to any pediatricians or to the hospital, how to approach? There are 4 components of the approach. One is patient characteristics, history taking, physical examination, and laboratory evaluations. So let's go for the patient characteristics. If you look at the cause of anemia, the patient characteristics also point to any particular etiology. As for example, if you look at the anemia in children are based upon age as presentation, whether she is a female or male, the race and ethnicity. So let's take an example. If the anemia is seen at neonate and young infants, mostly it's a immune hemolytic disease, or it could be due to infection, and hereditary disorders are most common. Usually, iron deficiency or nutritional deficiency are not seen at the young age, means in neonate or young infants. Similarly, if the anemia starts at about 3 to 6 months of age, probably we are dealing with a hemoglobinopathy. As you know, anemia starts after the 6 months, particularly so for thalassemia is concerned. So before the age of the 6 month, in terms of infant, the nutritional deficiency is very, very unlikely. In older children, the cause of anemia could be due to iron deficiency anemia, or which could be due to also blood loss. So you see, depending on the presentation of the anemia at the age particular, there can be more common causes to any particular age group also. So now let's see what is the importance of the history. If you look at the history taking, as for the few examples, X-linked diseases like G6PD deficiency, X-linked sideroblastic anemia are occur most common in males. As you know, it is a X-linked disease. The race and ethnicity, particularly hemoglobin S, C, and thalassemia or G6PD deficiency are confined to particular race and geographical areas also. Now, if you consider the symptoms of anemia, there could be changes. There is a change in the urine of the color. If the patient tells that intermittently my urine coloration becomes red or purple red or dark red, or there is scleral icterus, means lemon tinge icterus, or jaundice, which suggests it could be a hemolytic anemia disorder. If there is a bloody stool, hematomesis, severe epistaxis, or severe menstrual bleeding, suggests anemia could be due to blood loss or iron deficiency. If there is an infectious symptoms like fever come, it suggests probably it's an infective etiology to explain the anemia. Similarly, prior history of anemia is also important. If you take the prior episodes of anemia which suggest an inherited disorder, if there is the same disorder or the anemia is persistent from the childhood, or the other family members are present, or his siblings also still having the anemia, probably it is an inherited anemic disorder. Anemia in a patient with the previously documented normal CBC suggests an acquired etiology. If the hemoglobin is 12 or 13, then he suddenly develops the anemia after the age of the 5 or 6. Probably it's not an inherited disorder. Hyperbilirubinemia in a newborn period suggests a hemolytic etiology, and microcytic at birth suggests chronic intrauterine blood loss or thalassemia. So these are the history or some of the interesting history findings which can give rise to, which probably suggest some underlying etiology. Another example is that if there is underlying medical conditions, medical conditions like renal disease, malignancies, and or inflammatory autoimmune disorders may be associated with the anemia. Similarly, drugs and toxins and family history also can play an important role in deciding the etiology. Another example is the dietary history. As you know, in the infants and young children, iron deficiency is suggested by the following use of the low iron formula, or excessive milk intake, or excessive cow's milk intake, or if a female or if a child is a vegetarian, probably he could be having a B12 or folic acid deficiency. So dietary history is also very, very important. And medical history, if there is a travel history from areas of the endemic infection, suggest infective etiology such as malaria, tuberculosis. Similarly, developmental history like developmental delay is associated with iron deficiency or vitamin B12 or folic acid deficiency or Fanconi's anemia. So these are the important points in the history which probably will help you in ascertaining the primary etiology of the anemia. Now let's go to the another important component of approach is your physical examination. As you know, the physical examination or the clinical evaluation is most important. If you look at the skin, hyperpigmentation must suggest Fanconi's anemia. Similar, fatigue or purpura suggests autoimmune hemolytic anemia or thrombocytopenia or hemolytic uremic syndrome or bone marrow infiltration. Similarly, carotenemia suggests iron deficiency. Jaundice suggests hemolytic anemia, hepatitis or aplastic anemia. Ulcer on the lower extremity, they probably deals with the sickle cell disease or hemoglobin C disease. The cavernous hemangioma probably indicates microangiopathic hemolytic anemia. So these are the few examples. Finding a typical skin lesions point to another etiology. Similarly, if your eye microcornea indicates Fanconi's anemia, tortuosity of the congenital and retinal vessels indicates a sickle cell disease, you know. Microaneurysm of the retinal vessels, again sickle cell. A cataract G6 deficiency or hemolytic anemia. So vitreous hemorrhage, it could be due to, again sickle cell disease. Similar retinal hemorrhages, it could be chronic or severe anemia. Edema of the eyelid and blindness, they also lead to similarly peculiar diseases which has been mentioned here. Now, so physical findings could be the clue to the etiology of anemia in children. As for example, if you look at the typical facies like frontal brushing, prominence of the malar and maxillary bones, they probably we are dealing with a congenital hemolytic anemia. Similarly, on the mouth, if you find glossitis, angular stomatitis, they are more common with vitamin B12 and iron deficiency. If you look at the chest finding, unilateral absence of the pectoral muscles, or it could be due to any leukemia or sealed chest, it could be Diamond-Blackburn syndrome. Similarly, if you look at hands, some bony abnormalities which probably indicates we are dealing with inherited bone marrow syndromes. Similarly, sphenical enlargement, probably we are dealing with a congenital hemolytic anemia, leukemia, lymphoma, acute infection, or portal hypertension. So these are the few examples how the important clinical features also going to help you the primary etiology. And then the fourth one is another very important, because without this you cannot confirm the diagnosis, is your lab evaluation. Look, approach to anemia is always a clinical, is integration of your history, the clinical finding, and laboratory findings also. On the laboratory finding, we have three important things. You have a complete blood count with red blood cells indices, peripheral blood smear evaluation is a must, and the reticulocyte count. So these are the three important parameters in approaching a case of anemia. Here is a very, very important, few examples. These normal red cells looks like this biconvex discs. These macrocytes larger than this, it indicates probability of megaloblastic anemia. Microcytes, smaller size, indicates iron deficiency anemia or thalassemia. Penicillin-like cells indicates iron deficiency. Teardrop cells indicates probably it could be myelofibrosis, extramedullary hematopoiesis. Target cells again indicates probably it's a liver disease, hemoglobinopathies or hemolytic anemia. How will their body like things? They probably indicates nuclear inclusion or post-splenectomy. Similarly, on the right side, you have so many peculiar features which indicates peculiarity of any particular disease, which are there in the textbook also. I'll skip it. If you look at the peripheral smear examination, these are the peculiarity of the microcytic hyperchromic anemia. This is a classic of iron deficiency. If these features are there, if the red cells are small size and there is a hypochromasia, means the central pallor is enhanced, means more than the 50% of the normal cell, we call it as a microcytic hyperchromic anemia. This is possible in iron deficiency anemia, thalassemia minor and sideroblastic anemia. Similarly, if you find macrocytes, we call it as a megaloblastic anemia. These are the typical sickle cells. These are the spirocytes, which indicates probably hereditary spirocytosis or in a autoimmune hemolytic anemia. These are the target cells. I have already told you, these target cells seen in thalassemia, all other hemoglobinopathies. These are the cystocytes. These are the Bott cells or the Bohr cells. So on looking on the peripheral pictures, you can really give a very good diagnosis. As for example, on the bottom, you find there is a relax formations, which probably due to the hypergamma-globulinemia, which is a classic feature of the multiple myeloma. Similarly, if you have autoagglutination, so by drawing the sample, you find that the sample gets like that, or the RBC morphology like that, probably you are doing with the autoimmune hemolytic anemia, which is of a cold type mainly. And the normal red cells looks like this. So biconvex disc with the central pallor like that. So these are, so the peripheral evaluation or the peripheral blood examinations and the red cell indices plays a very important role in deciding for that. So diagnostic approach in isolated anemia in children, if you look at the morphologic evaluation, you have a low hemoglobin level with, if it is less than 2.5 percentile of the age, race and sex, your hemoglobin level. So then you decide, so does the child is having anemia or no? If there is a no, then you can ignore. If there is a yes, there is a anemia, then you look for the MCV. You know the normal MCV, we call it as 80 to 100 femtoliter. If the MCV is low, means less than 80, so these are the possibility. Iron deficiency anemia, I have already told, it could be thalassemia minor or sideroblastic anemia or anemia of chronic disease. So if the MCV is less than 80 femtoliter, which can be well known from the CBC parameter, so these are the four possibilities, and you have to go for the subsequent further evaluation to confirm your diagnosis. As for example, if it's a iron deficiency anemia, you have to go for the iron profile study, including serum ferritin, your transferrin saturation, so on, to confirm that there is a iron deficiency. If it's a thalassemia minor, you should go for the HPLC testing or automated capillary zone electrophoresis to confirm that yes, you are dealing with thalassemia minor. If it is a other disease, so if the MCV is normal, so these are the possibility. It could be if the MCV is a normal, means it varies from 80 to 100. Then you look at the reticulocyte count. If the reticulocyte count is low, then it could be due to infection, drugs, lead poisoning, acute blood loss, anemia of the chronic disease or renal disease. Or these are the possibility if the reticulocyte count is less. If the reticulocyte count is more, then these are the possibility. It could be hemolytic anemia or could be due to blood loss. I have already discussed hemolytic anemia. It could be due to membranopathy. It could be due to the hemoglobinopathy. It could be due to the enzymatic deficiency. It could be due to also microangiopathic hemolytic anemia. And you have to go for the further evaluation to confirm the etiology. If it is hemorrhage, you look for the possible causes of the hemorrhage, history, your clinical evaluation, all scope, endoscopy, colonoscopy, all or even your radiological evaluation to find the site of the lesion. If it is high MCV, means more than 100 femtoliter, it's a macrocytic anemia. The common cause is drug intake. It could be vitamin B12 or folic deficiency, immune hemolytic anemia, Diamond-Blackman syndrome, liver disease, hypothyroidism, so these are, or myelodysplastic syndrome. So these are the common causes where the MCV can be high. So the laboratory evaluation to integrate the CBC with peripheral blood smear, same thing is just a integration. If you have a normal MCV with a less than or with a less reticulocyte count, means less than 3%, You review this smear, so these are the findings. If you look at, then these are the possibility diagnosis, and you should go for the further evaluation by reviewing the medication, the bacterial culture, and bone marrow aspiration and biopsy. If you find that you have a normal MCB with a high reticulocyte count, you have to review the peripheral smear to exclude the enzymopathy, to exclude your membranopathy, means to spirocytes or hereditary elliptocytes or fragmented red cell. Then you have to go for this your diet test or comb test to exclude whether it is autoimmune hemolytic anemia. If you have a high MCB with check the peripheral blood smear, I have already told you the causes of the megaloblastic anemia. Then you have to review the medications. So go for the review of the dietary history. So go for the serum B12 and folic acid level, thyroid function test, osmotic fragility, hemoglobin electrophoresis, so diet and bone marrow biopsy and aspiration. So these are the investigations which should be done in a macrocytic anemia to find the possible etiology. So this is the last slide probably. Diagnostic approach to child with anemia of abnormality of other cell lines. If along with the hemoglobin less, if you find that is abnormality in the TLC or platelet count, then these are the possibility. If you look at there is a pancytopenia, the possibility could be leukemia, myelodysplastic syndrome, aplastic anemia, hypersplenism, infections, or B12 and folic acid deficiency. If anemia is with a low platelet count, it could be hemolytic uremic syndrome, or TTP, DIC, or event syndrome. If anemia with a high platelet count, it could be iron deficiency, infection, and post-splenectomy anemia. If anemia with a high WBC count, it could be infection and leukemia. So you again review this smear, then only you can reach for the diagnosis, and then depending on your review of the smear, you can go for the further evaluation like medication history, dietary history, serum ferritin, iron level, serum B12 and folic acid, indirect bilirubin, LDH, and haptoglobin, which are the marker of the hemolysis, comb test, bacterial culture and viral studies to exclude the infections, and bone marrow biopsy and aspirate. So these are the further evaluation. You can confirm the possible causes if there is other cell lines are affected. With this to conclude, ladies and gentlemen, the take-home messages are that so anemia is defined if the hemoglobin or hematocrit is less than 2.5 percentile of the age and sex. The cause of the anemia vary based upon age and presentation. History and physical examination is the key. So laboratory evaluation begins with a complete blood count, include red blood cell indices, reticulocyte count, and review of the peripheral blood smear. The mean corpuscular volume provides a preliminary categorization of the anemia, which is a microcytic, normocytic, or a macrocytic. The reticulocyte count distinguishes the disorder, whether you are dealing with a rapid destruction or loss of the RBC, or inability to adequately produce the RBC in the bone marrow in response to the anemia. That's the importance of reticulocyte count. So thank you very much for your attention.